In this video, I will show how I handled the complication of an early posterior capsule rupture. This was a soft PSC, so I began with the Akahoshi pre-chopper. The nucleus did not crack, so I went back to divide and conquer. My second instrument was used to rotate the lens slightly to align with my phaco groove. On my third groove, I noticed the posterior capsule rupture. We injected viscoelastic and noted there was no vitreous prolapse, so we proceeded with very gentle nucleus removal. During the case, we tamponade the posterior capsule rupture many times with viscoelastic. I take care to aspirate only with full occlusion and use my second instrument both to guide the pieces in and also to protect the area of the open posterior capsule rupture. When I rotate the heminucleus, I have to take care not to catch it on the posterior capsule. Despite the large piece, it is best to remove in as few pieces as possible. Looking back, I noticed that this was only a 3.5 millimeter lens thickness, and I now check the lens thickness before every case. My attending puts pressure on the wound to prevent it from burping, much like removing a DMEC injector. INA proceeds with similar principles of aspiration only with full occlusion. At the area of the tear, it is important to pull towards the tear, not away from it. Here I was too aggressive with viscoelastic injection, and that pressure ended up enlarging the tear. I filled the sulcus in preparation of placing a sulcus lens. The incision was also recently enlarged. The leading haptic makes it into the sulcus, but then it prolapses into the AC. It is gently repositioned. I perform optic capture. However, while pushing the lens down, it ends up enlarging the PC tear. I inject Myostat, and then after the pupil comes down, we prehydrate the wound before INA to also minimize wound burping. We suture the main wound, and we once again check to make sure that there is no vitreous.